Hello and welcome to BunMed. Today we will be looking at the leukemias. Specifically, we will be looking at the cell lineages and how this not only relates to the symptoms of the leukemias, but also what we may see on a full blood count. In leukemia, the leuk refers to white and emia, the blood. Thus, leukemias are conditions where we have an excess of white blood cells in our blood. But where did these cells come from? From what lineage do they come? Well, it all starts with the hematopoietic stem cell. Hem referring to blood, and poietic referring to the synthesis of. Thus, this cell goes on to form all of the cells in our blood. Now, this cell can either go down the myeloid route or the lymphoid route. Here we see the cell going down the lymphoid route, and it becomes a lymphoblast. Here, the blast refers to an immature cell. Thus, a lymphoblast is an immature cell of the lymphoid lineage. This cell may then further differentiate to go on to form some of the most important cells of our acquired immune system. This includes the B cells, which are responsible for producing specific antibodies to deal with infections, the coordinators and the helper T cells, which are currently being drawn in here, who coordinate the specific immune response, and of course our assassins, the natural killer cells, who kill cancerous tissue as well as viral infections. We may also have the cell going down the myeloid route, where it becomes a myeloblast, myelo referring to the lineage, blast referring to its immature nature. And here it may further differentiate to go on to form the red blood cell, which carries hemoglobin and oxygen around our body. It may go on to form the granulocytes, which include the cells responsible as the first line of defense in our acute immune response, such as the first responders, like the neutrophils. They may further go on to form the cells responsible for dealing with parasitic infections in our body, the eosinophils. And lastly, they may go on to form the basophils, a group of cells that's quite mysterious and we're not quite sure exactly what their role is. They may go on to form the monocytes, the cells responsible for bridging the specific and non-specific immune system. And finally, they may go on to form the megakaryocytes, who are responsible for bursting and producing platelets, which are responsible for helping us clot and stop us bleeding. So now that we have a basic understanding of how the cells come to be and what lineages they come from and how they're roughly organized, let's get into a little bit about the leukemias. So today I'll be talking about four types of leukemias. I'll be speaking of the acute lymphoblastic leukemia, the ALL. I'll be speaking about the chronic lymphocytic leukemia, the CLL. I'll be speaking about the acute myeloid leukemia, AML, and we'll also lastly be speaking about the chronic myeloid leukemias, the CML. And we're going to try to bring everything together about how these leukemias relate to what we've drawn out in our cell lineage diagrams. So let's start with acute lymphoblastic leukemia. The acute refers to quick onset. Lymphoblastic, we know something to do with the lymphoblast, so down the lymphoid lineage. And leukemia, referring to lots of the lymphoblasts in the blood. Thus, acute lymphoblastic leukemia is a condition where we have lots and lots of lymphoblasts in our blood. So how does that actually happen? What occurs? Well, we tend to have some kind of genetic mutation in the hematopoietic stem cell, which causes our lymphoblasts to start dividing uncontrollably, a process which is often very, very tightly controlled under normal circumstances. These rapidly dividing lymphoblasts then go on to infiltrate some structures around our body, including our bone marrow, our spleen, as well as our liver. Now, what sort of things might we actually see when things like these occur? Well, if we're having more cells going down lymphoblasts and less making myeloblasts, we have less red cells being made. So what might we see? Well, we might see signs and symptoms of anemia like tired all the time, things like fatigued, things of pupils not being able to keep up in school. These are all symptoms of anemia and indeed symptoms of acute lymphoblastic leukemia. Another symptom of anemia might be breathlessness that children often tend to experience as well as adults. What else might we see? Well, if we're getting less myeloblasts being produced, we are of course going to have less granulocytes also being produced, as you can see. If we get less granulocytes being produced, we get less neutrophils being produced. What does this mean? Well, we've knocked out our very first layer of immunity inside our body, and therefore we can't as effectively combat infections. So we tend to get severe and recurrent infections. Severe because we can't respond to them as quickly, and recurrent again because we can't deal with the threat inside of our bodies. What else might we see? Well, again, if we are having less myeloblasts being produced, we are going to have less megakaryocytes being produced, thus less platelets being produced, meaning we can't clot. So children often get nosebleeds, the posh word for this being epistaxis. The other thing you might see is a purpuric rash, which is like a type of rash underneath the skin due to under the skin bleeding. So we talked about infiltration of the bone. Therefore, we might see things like bone pain going on as well, which often children complain of. And as well as the early satiety, because as our spleen enlarges, it pushes on the stomach, and therefore we can't eat as much. Okay, so that's some of the stuff we can look for in history. What about on examination? Well, on examination, we might start to notice some of the features of anemia, so pallor or paleness of the skin, and indeed the conjunctival surfaces like under the eyelids is very common. We might see symptoms of thrombocytopenia, so this includes bruises and a purpuric rash all over the body. And lastly, remember we have infiltration inside of our spleen. And due to this, we might end up seeing something called splenomegaly, which is enlargement of the spleen due to the spleen being infiltrated. The other reason splenomegaly may occur is due to the red blood cells not being able to be formed as effectively in the bone marrow. Thus, we get extramedullary hematopoiesis. So, this is production of red blood cells outside of the bone marrow. And one of the organs that do this is actually our spleen. So, as this kicks in, the spleen goes into hyperdrive and becomes large. Another organ to become infiltrated is the liver. Thus, we may get hepatomegaly. Um, Due to infiltration of the lymphoblasts into the liver. And finally, what might we actually see on a full blood count? Because of course this is the most important first line investigation to do to actually work out what's going on inside our blood. Well, we will definitely see an anemia. And what type of anemia will we see? In most cases, we will see a normocytic normochromic anemia. This means the cells are the same size and contain the same amount of hemoglobin, but there are just not enough cells to go around due to infiltration of that bone marrow. We may also see a thrombocytopenia, as we simply are not producing enough platelets as we are not producing enough myeloblasts. We may also get a neutropenia, as again we're producing less myeloblasts, thus we simply can't produce enough granulocytes. So this is what often leads to the severe and recurrent infections that we were talking about earlier. And finally, remember, we actually have this is a leukemia, so we have lots of white cells in the blood. Well, indeed, we're going to have a leukocytosis due to there being so many lymphoblasts. And in fact, if we look a little bit closer in, say for instance, if we were to do a blood film, what we end up seeing is leukemic lymphoblasts. So lastly, what kind of population groups are we likely to see acute lymphoblastic leukemia in? Well, in general, we tend to see these in children, and we're looking at the age range of roughly 2 to 5 years when it peaks. It also seems to be more prevalent in boys rather than in girls. Okay, so let's talk about chronic lymphocytic leukemia. So what can we learn from chronic lymphocytic leukemia? Well, chronic means a long-term condition that's usually slow to come on. Lymphocytic refers to the fact that we're again going down the lymphoid lineage, but other than last time of having immature cells, this time we have mature lymphocytes, mainly the B lymphocytes. And leukemia just means there's a lot of them in the blood. Thus, chronic lymphocytic leukemia refers to a condition where we have lots and lots of mature lymphocytes in our blood. So how does this occur? Well, unlike last time where we saw that lymphoblasts have a mutation which causes them to proliferate uncontrollably, we actually this time get a buildup of mutations in our lymphocytes, which stops them from dying normally or avoids apoptosis, causing them to build up in the blood. Once they build up, they may infiltrate structures like our liver, they might infiltrate our spleen, and just like last time, they might actually also go on to infiltrate our bone marrow, and as well as that, they may infiltrate our lymph nodes. So how might we actually see this in our symptoms? Well, in actuality, the symptoms seems to be very similar to last time, although they come on significantly more gradually than they did. So because of the infiltration of the bone marrow, we might get symptoms of anemia, which includes fatigue. They might be tired all the time, just like last time. They might have shortness of breath, and even sometimes palpitations where the heart is racing. Because of the infiltration of the bone marrow, we might also get severe and recurrent infections as we're not again getting granulocyte production. We might get things like spontaneous bruising or even easy bruising due to us simply not producing enough megakaryocytes and thus by extension not producing enough platelets. As well as this, the patient may notice some rapidly enlarging lymph nodes or a rapidly enlarging lump on their neck or under their armpits. With this, we must ask about some specific questions, and this includes night sweats, so these are drenching night sweats where they have to change the sheets, any weight loss, and any unexplained fevers. Now, the reason for this is that chronic lymphocytic leukemia can actually transform into a very, very deadly, rapidly progressive, large B cell lymphoma. So therefore, anytime we have very, very fast lymphadenopathy, it's good to get a biopsy of the lymph node and just make sure that it hasn't transformed. Okay, so in terms of examinations, what are we going to notice? Well, on examination, we're likely going to notice a lot of the same things that we have seen with acute lymphoid leukemia. Things for these include signs and symptoms of anemia. So pallor is up there, purpuric rashes, or any bruising over the skin. On top of this, we might palpate a splenomegaly. We might, due to infiltration of the spleen, we might see hepatomegaly on top of this as well, although this is a bit more uncommon in chronic lymphocytic leukemia. As well as this, we might also palpate a lymph node in the neck or in the armpits, or just in general lymphadenopathy. Finally, what are we going to see on a full blood count? Well, on a full blood count, just like much earlier, we're going to notice an anemia. Specifically, once again, we're going to notice a normocytic, normochromic anemia. As we have the bone marrow being plunged up with these lymphocytes, there's less space for granulocyte formation. So we're going to see less neutrophils. So we might see a neutropenia. We may also go on to see a thrombocytopenia for the almost the same reason, as the megakaryocytes are not being produced. And we're obviously going to see a leukocytosis because we have so many of these non-dying B cells circulating in our blood. It tends to mainly be the B cells affected. Lastly, just to tie it in, if we do a peripheral blood smear, we might actually end up seeing something called smear cells. Now, we must realize that because the cells aren't dying, the cell's extracellular structure and just the general structure of the cell is a lot weaker. So therefore, when we take a blood smear and we put it on a plate and we smear it, the cell actually bursts and it gives the appearance of these smear cells. So what kind of populations group do we get to see chronic lymphocytic leukemia in? Well, it tends to be mainly elderly people, so a slightly weak risk factors being male, but those usually over the age of 60 tend to suffer from chronic lymphocytic leukemia. We've briefly talked about the lymphoid leukemias. Now let's have a look at the myeloid leukemias. And a good place to start is with acute myeloid leukemia. So what can we actually tell from acute myeloid leukemia? Well, sometimes this is called acute myeloblastic leukemia. So just like last time, we know that this is going to be a condition that comes on quite quickly. Myeloblastic, so we know it's going to involve quite a lot of immature myeloid cells. And leukemia simply means there's lots of them in the blood. So we're going to see a condition where we have lots and lots of immature myeloblasts in our blood, and the symptoms come quickly. So how does this occur? Well, just like with ALL, we get some sort of genetic mutations to our myeloblasts, which causes them to divide uncontrollably and rather rapidly. As this division occurs, they tend to build up in our peripheral blood, and as such, they go on to infiltrate all the structures that we've talked about before. So these include things like our bone marrow, our spleen, our liver, and as well as that, our lymph nodes that we've seen, just like in CLL. We might also, quite strangely enough, in acute myeloid leukemia, get infiltration of our gums. So we tend to get gum hypertrophy. So here you can see a face with some gums being drawn on it, and the red kind of shows that it's being infiltrated on a rather nightmarish face. Okay, so what kind of signs and symptoms might we see? So in terms of symptoms, it's just going to be like last time. Because we have that infiltration, we're going to get signs and symptoms of anemia. So fatigue, tiredness, shortness of breath, palpitation, some dizziness. You're going to get symptoms of neutropenia, so things like severe and recurrent infections. We're going to get symptoms of thrombocytopenia, so epistaxis, so nosebleeds, bleeding from the gums, okay, petechiae, purpura, ecchymosis, which is the posh word for bruising all over the skin, okay. We might get enlargement of the spleen, again causing things like early satiety. Wondering, hang on a second, we have so many myeloblasts. Why are we still getting these symptoms of anemia, neutropenia, and thrombocytopenia if myeloblasts are needed to make myelocytes? Well, the issue is that these myeloblasts are actually dysfunctional, so they don't actually evolve or mature into our myelocytes, and they're forever stuck in this myeloblastic phase. Not only that, they seem to release these cytokines that actually physically go on to stop hematopoiesis. So what you end up with is a dysfunctional immune system. So moving on, what are we going to see on examination? Well, again, we're going to see symptoms of anemia, so pallor of the mucosal surfaces. We're going to see things like purpura or petechiae due to the thrombocytopenia. We might palpate a splenomegaly, a hepatomegaly. This one is the odd one where we get infiltration of the gums, so we might see some gum hypertrophy, so enlargement of the gums. And lastly, we might palpate a lymphadenopathy, which simply just means enlargement of the lymph nodes, okay? So moving on, what are we actually going to see on a full blood count? Well, on a full blood count, just like last time, we're going to see an anemia. What type? Again, normocytic, normochromic anemia. We may go on to see some thrombocytopenia, and we may also go on to see some neutropenia, just like we did last time. We may see things like a leukocytosis, and on a peripheral blood smear, we might see leukemic blasts. Now, I know what people are thinking. It's like, well, that sounds almost exactly the same as ALL, so how do we go differentiating the two of them? Well, it turns out that the amount of changes that the myeloblasts going through actually put a lot of stress on the cells. And this causes some of the enzymes inside the cells to actually crystallize out and precipitate out into these hour rods. And under the microscope, you can actually see these hour rods, which are crystalline myeloperoxidase enzymes. So anytime you see a question that says hour rods, think acute myelocytic leukemia. So what kind of population group are we going to see this in? Well, just like in chronic lymphocytic leukemia, not acute, we actually tend to see this in elderly people, so people over the age of 65. We tend to see this in those who have had previous chemotherapy. And lastly, we tend to see these in people who have other myeloproliferative disorders. So myeloproliferative means something of the bone marrow that's proliferating. So these are things like myelofibrosis, where our bone marrow becomes physically scarred or we might get myelodysplasia, which is like acute myeloid leukemia. Just simply we haven't hit the cell count needed to be classified as acute myeloid leukemia. Okay, so we've talked about the acute myeloid leukemia. Now let's talk briefly about chronic myeloid leukemia. So what do we actually mean by chronic myeloid leukemia? Well, from the word chronic, we know it's going to be a condition that takes some time to come on. Myeloid, we know it's going down that myeloid lineage again, and leukemia means we're going to have lots of white cells in the blood. Thus, chronic myeloid leukemia is a condition where we're going to have lots and lots of white cells of the myeloid lineage in the blood. And this time, unlike last time of immature cells, we actually end up having mature myeloid cells in our blood. So how does this happen? Well, we get some sort of genetic mutation to our hematopoietic stem cell. And this one's actually very specific, so we get a translocation reaction, which is essentially when two chromosomes, in this case C9 and C22, merge together. So the top part of C22 and the bottom part of C29 go on to form this mutant chromosome known as the Philadelphia chromosome. Now, because they've now been put next to each other, it puts this very special region next to each other. And because of this reason, we actually get two genes being put next to each other. And this is known as the BCR-ABL gene. And this BCR-ABL gene actually goes on to code for the BCR-ABL protein, which then goes on to activate tyrosine kinase receptors in our hematopoietic stem cells, which essentially goes on to cause them to proliferate uncontrollably. The excessive cells go on to infiltrate all of the structures that we saw before, including the bone marrow, the spleen, and etc. So what kind of symptoms do we see? Well, again, we start to see these symptoms of anemia, so things like shortness of breath, tired all the time, fatigue, palpitations. There's a recurrent theme here that we're starting to see. We get not enough granulocytes being produced, so we get severe and recurrent infections. We might get bruising, spontaneous or easy bruising due to just not producing enough platelets. Patients might get early satiety because of that splenomegaly and that spleen pushing on their stomach once again. So what kind of things might we expect to see on examination? Well, just like before on an examination, we're starting to look for signs and symptoms of anemia, so pallor of the mucosal surfaces, any bruising on the skin or any ecchymosis that we can see. Can we palpate a splenomegaly? And in these cases, it tends to be a massive splenomegaly. It's one of the few cases that actually gives you a massive splenomegaly. We might get a hepatomegaly, which means that the liver is again enlarged, and we might get lymphadenopathy when the lymph nodes get infiltrated. Now, you're probably wondering, hang on, this doesn't make sense. We're now getting mature blasts, but why are we getting signs and symptoms of anemia? Well, it turns out that the mutation that occurs causes the cells to proliferate, sure, but they're maturing very, very slowly. So we don't actually get these mature cells. In fact, what we end up getting on a full blood count, other than the anemia, which is normocytic normochromic, other than the neutropenia, which is and the thrombocytopenia, we actually tend to see a leukocytosis with developing bands. These bands are cells which are slowly developing, however, have not fully developed. That's the consequence of the BCR-ABL mutation. These cells are always maturing, but never quite reaching maturation. Okay. What kind of population groups do we see? Again, all other than the acute lymphoblastic leukemias, all other ones are elderly people over the age of 65. Now, you're probably wondering, hang on, why did we dive into such great depth about the pathophysiology of CML and ignore the other one? Well, understanding that the BCR-ABL protein goes on to activate the tyrosine kinase receptors, we can actually use this to work out what kind of treatment they might need. And a very, very effective treatment for CML is imatinib. Imatinib is a tyrosine kinase inhibitor. Thus, if we can inhibit the tyrosine kinase receptor, which when acted upon causes our cells to proliferate uncontrollably, we can actually stop them proliferating. So imatinib is very, very effective in the treatment of chronic myeloid leukemia. A massive thank you to everyone who's actually put up through the video. I know it's been a very, very long video, but I do hope that it's at least helped people to understand roughly where about the leukemias come from and some basic ideas about why they are how they are. If you have any questions, please do let me know in the comments and I'll try to get back to them as soon as possible. Thank you again.